everybody. Thank you for coming. We're going to get started on this panel for exercise and rehabilitation programs. And I'd like to introduce you to our panel. We have Michael Lewis, Daniel Fox, Rebecca Fenton, and Roxanne Silica. Thank you guys so much for coming.
Thank you.
Thank you. Thank you. So I think I'll begin by introducing the session to you. It's a very complex relationship that the patient with pulmonary hypertension has with exercise, right? So I keep asking patients when I first see them, how short of breath are you? Oh, I'm not short of breath at all. Really? Only when I walk. It's a very complex relationship, and as you very well know, I'm sure way better than anybody at this table, that's the first thing that you feel, like your exercise capacity is not the way it used to be. All right, so that's one aspect that we're going to discuss about. And we use your exercise capacity as a way of figuring out exactly how your right heart is doing, how your right ventricle is doing, how your entire body is actually doing and is able to handle the increased workload. We also, are gaining more and more, and we're going to have actually a special 7 minutes discussion about the new data that we learn about the abnormalities that are happening in the patient with pulmonary hypertension, because it's not only the right side of the heart is not working properly. The right side of the heart is not able to compensate for the increase in the cardiac output that you require with exertion. It's more than that. It's much more complicated. It's probably a systemic disease. Your muscles here are actually suffering as well. Your diaphragm and other respiratory muscles are also suffering. So it's like a systemic disease, and this is actually data that's fairly recent, and we are going to learn specifically about that from the experts here. The other thing that we are learning about pulmonary hypertension is the fact, and exercise, is the fact that actually if you start getting the patient to train physically, you can improve their functional capacity. You can improve their oxygenation, and you can improve their quality of life. People that go through cardiac and pulmonary rehabilitation programs, they do better, and we know that. And, heart failure and COPD, they are ages, ahead of us. But we are actually coming up with new data specifically, from patients with pulmonary hypertension, and then we'll have, specific discussion about rehab and pulmonary hypertension. And finally, we're going to talk about a couple of types of exercise that are recommended for patients with pulmonary hypertension. Now, I think we are going to be fairly brief. We only have 7 minutes apiece, of talking, and then the floor is yours, and we are here to answer any question that you may have.
Well, it's my pleasure to be here. I'm from Cedars-Sinai in Los Angeles. Been dealing with patients with pulmonary hypertension even before therapies were available. So when it comes to feeling short of breath with effort and having impaired ability to exercise, you could ask the question, well, why is that? And it's, as was already mentioned, it's a very complex interaction between a whole variety of systems, which I usually divide into central, which is the impact that the heart as a pump has, particularly the right heart, and inability to provide adequate amounts of oxygen with exercise. The lungs, the central, also within the chest cavity, the lungs, which because of abnormalities have a heightened demand to breathe in order to produce the correct amount of oxygen in the blood and carbon dioxide. But then the part that I'm going to concentrate on, and others will talk about other aspects, is the peripheral side. And that is the side that the respiratory or the breathing muscles play. and the limb muscles that we use to walk. So the respiratory muscles you can think of as the pump of the lungs, much like the heart is the pump of the circulation. And the respiratory muscles, there are many inspiratory muscles, muscles that allow us to breathe in, to expand the rib cage, to allow pressures to fall so that we draw oxygen and air into the lungs for the purposes of providing oxygen to the body, getting rid of carbon dioxide. And the three main respiratory muscles, the one is the diaphragm. That's this muscle that separates the chest cavity and the abdominal compartment. And that is responsible for expanding the lower rib cage. It doesn't expand the upper rib cage, but there's a group of muscles that are called the parasternal intercostals that are alongside the sternum on each side here, that are also primary inspiratory muscles, meaning that if we had to put in a needle electrode, you'd see the diaphragm, the parasternal intercostals, and then the neck muscles, the scalene muscles. If you had needles into them, every single time each of us breathe, there's going to be activity. And this activity will continue throughout life. There are other muscles that we call upon to help under times of stress as well. So it turns out that first initially in heart failure, and many, many years ago, we did studies in which we induced heart failure in many pigs and looked at diaphragm function and other functions. And we found that with heart failure that the diaphragm was markedly abnormal. And this kind of data has been translated and shown in patients. So patients with pulmonary hypertension specifically, a longer track record, patients with heart failure, do have weak respiratory muscles. And the muscle that's been most tested, because it's the easiest one to test, is the diaphragm. And this is weak whether we do special tests in which the patient tries to produce the biggest effort they can. That's called volitional. But sometimes it's hard for patients to do that. So we have non-volitional tests where we can stimulate the nerve to the diaphragm in the neck using electrical or magnetic stimulation and measure a twitch of the diaphragm and assess the strength of the diaphragm that way. And in both circumstances, respiratory muscle strength is decreased. The other thing that we find as well in the respiratory muscles is that the ability to continue to work, or what we call endurance, is also compromised. And part of that is because the muscles are weak, and part of that is also because certain organelles within the muscle cells called the mitochondria are abnormal, and they produce enzymes that help to facilitate the use of oxygen in the body, and those are low. And then the last thing I'll mention before I move on to the limbs is that if you take a muscle and you work out what the maximum amount of strength that that muscle can produce, and then, so let's say the diaphragm, and then you measure what strength is required, for example, just to breathe, and let's say the maximum is 100 centimeters of water pressure. For most of us sitting in the room here, it probably is in the region of 5 to 7 centimeters of water pressure. So you're using only about 5% of the maximum. However, if somebody is stressed and if the total force goes down, then the ratio of what you're using, not 5%, it's going to, if it exceeds 40%, then that muscle cannot sustain action for any length of time. And then also, as the ratio of the amount of force you're using to breathe as a percentage of the maximum increases, this has a very strong correlate with a sense of magnitude of task and shortness of breath. Within the limb muscles, the same kind of thing has been observed in that both leg muscles, which are the muscles of, ambulation, as well as the arm muscles are also weak Part of the reason for the weakness in both sets is that some of the muscle fibers shrink. And they shrink, why? Because of a whole array of complex metabolic factors, but the bottom line is that they stimulate the activation of pathways within the body that help to break down proteins, and in particular muscle proteins, and also help to decrease some of these oxidative enzymes. And with this, you get a decrease sometimes in the microcirculation or the blood flow within these muscles as well. So there's the tiny little blood vessels, capillaries, are also decreased. So the reason why I bring this all up is that a lot of work has been done in the rehabilitation field. And in fact, at the last World Conference on pulmonary hypertension in Nice in 2013, pulmonary rehabilitation was given a grade 1A recommendation, whereas when I first started in the field of PH, people were very cautious to exercise patients because they said the pulmonary vascular bed is constricted, all this remodeling of the little vessels, and so if you're starting to push increased amounts of blood through that, maybe that's going to harm the right heart. But that turns out not to be the case, and it in fact turns out not to be the case for patients with even class 4 functional class 4 pulmonary hypertension. So the studies that have been done, there is a meta-analysis that looks at 16 studies, 434 patients. They all show a significant increase in 6-minute walk. And in fact, the largest study is the one from Germany by Grunig and colleagues. They showed after 3 weeks of pulmonary rehab, the increase in 6-minute walk was 68 meters. And after 15 weeks at home, they did a 12-week session at home. Following that, it was 78 meters. And in the meta-analysis, with all these 16 studies, it was 57 meters. Those are phenomenal numbers, better than sometimes we see with the pharmacologic studies that have been reported and that obtained approval from the FDA. Quality of life also has been shown to improve. And then if you take biopsies of limb muscles, you can show that there can be improvements, there is improvement in capillarity and in some of these oxidative enzymes, and a decrease in the systems that tend to break down muscle, and there may be a tendency to improve muscle mass. And also, the last thing I'll mention, although it is complex, I'm trying to keep this as simple as I can, but muscles are made up of different types of fibers. So there is a conversion from, for example, in the diaphragm, from fibers that are very fatigable to those that are more resistant and can sustain effort. So I think I've probably taken up at least 7 minutes, which is supposed to be the time. So I'll stop there and I'll be happy to answer any more questions.
I think, should we do questions now or should we do it at the end? Okay. Perfect. So.
All right, I'll jump in next. So my name is Dan Fox. I am currently at the University of Colorado, up at a Mile High. I'm from the Southeast. It's very cruel to have me talk after Dr. Lewis here because he sounds so elegant with his South African accent, and I'm from the South. I sound like a doofus. But
I still beat you up with my Romanian accent, so you can say anything there.
You sandwiched me between a bunch of intelligence up here. So first of all, it's great to be here. Really thrilled to be in such a venue as this. I always enjoy talking with patients about really a host of different things. But one of the things I've become increasingly passionate about with the patients that we see in our PH clinic in Denver is, one of the first things after we go through the diagnosis is, we talk about why patients feel short of breath. Why am I short of breath? Well, it's a good question. Why are you short of breath? So you guys know this better than me, certainly, but what is it that drives that shortness of breath? How do you describe it? This is actually an all play here. So I'm short of breath. What's that mean? Yeah, you can't breathe, right? So that's simply stated, you can't breathe. You can't get enough air in so that when you go to do stuff, you can't supply the blood to the muscles, okay? I'm a simpleton in many ways, and when you think about what this disease process is, yes, it's a disease of muscles, as Dr. Lewis just talked about, but it's also, can we pump the blood to the muscles efficiently? And so when you think about it from that point of view, exercise takes on a whole new, framework. How are we going to exercise? How are we going to make it so that my body can get the blood where I need to get it? And thinking about that simply, a very legitimate question is, can I exercise? Is it safe for me to exercise? That's one of the questions I get routinely. And the answer I always get is, there is not a disease I know of for which exercise is not helpful. I don't care if you have diabetes. I don't care if you have cancer. And I certainly don't care if you have, COPD. We know that that's the case. Heart failure, we know that's the case. But pulmonary hypertension is no exception. Exercise is helpful in this disease. And as Dr. Lewis mentioned, I think there's a couple of specific ways that exercise really helps. First of all, patients can walk farther after they do a dedicated cardiopulmonary rehab. Okay, we know that. He quoted, 58, 67 meters in some of the big studies. There are some smaller ones that, a little less sick cohort, they'll walk up to a football field further in 6 minutes. That's a huge life. That's a life changer for folks. That's not with adjustment of medicines. That's not with, changing the way you eat. That's just by going through 12 to 16 weeks of rehab. Okay, that means a lot. But even more important than that is when you look at patients who, before and after their cardiopulmonary rehab, one of the things that I've had patients tell me is that I just feel better. It's something that I own. You doctors mess with my medicines, but I own my exercise. It's my time. It's what I do. I do yoga. I do Pilates. I do, water aerobics. Whatever it is, that is something that I can control, independent of, us prescribers, which I think sometimes we get the God complex and think that our little titrations and medicines are making the difference. And oftentimes, it's the things that you're doing, the activities that you're initiating that really drive that quality of life. So, I think that there's a lot of benefits to what we're doing here. So, for my remaining 2.5 minutes here, what I wanted to talk about briefly is, what are the practical considerations of starting a rehab program? That's another, big challenge is, okay, you say I can exercise, but what can I do? Well, what you can't do is go say, I'm going to deadlift. I'm going to deadlift. I'm going to start by just lifting, 300 pounds. Well, why can't you do that? Well, part of it is that your muscles are deconditioned, okay? So the key to this is you've got to ease into your exercise and ease out of your exercise. And the reason for that is not only that it makes your muscles, gives them time to, acclimate to the exercise that you do, but it also, that easing in and easing out is going to be safest for your heart and lungs. What happens when you guys can speak to this better than I, but when you bear down or when you bend over, what happens when you have severe pulmonary hypertension? You get dizzy, lightheaded, you pass out. Why is that? Well, when we bear down and increase the pressure in our chest, that transiently makes it harder for blood to fill the right side of the heart. And that's obviously dangerous when the pressure's already high on the right side of the heart. So easing into your exercise, I'm going to start by walking and then I'll pick up my pace. I'm going to start by lifting very light weights and increase very gradually. That allows the heart and the lungs to kind of, work together to get to that sweet spot where you can do the maximum amount that you can do. I had a patient once tell me that they went to a gym and said, I want to start exercising, and they had them doing wind sprints. Not nice. The patient's like, I don't think that's right. Wind sprints, like, that didn't go so well, right? So, finding something, where you can ease into your exercise, I think is really valuable. For me, the practical considerations and the benefit of cardiopulmonary rehab is that it teaches you to learn your body. Exercise occurs in a monitored setting. They're checking your pulse. They're checking your oxygen. They're checking your blood pressure as you exercise. And once you learn the cues that your body gives you, you can then take a step back and say, I can do this. It builds confidence so that at home you can, I can do this. I'm going to walk. I'm going to do some stairs. I'm going to lift some weight. Whatever it is that you're going to do, It gives you the confidence to know what your body is telling you kind of on a moment-to-moment basis as you exercise. So, I'm going to stop there, and hopefully we'll have a lot of time for questions. But as you think about your cardiopulmonary rehab and introducing it, perhaps in this venue, I think the take-home points from me that I want you to hear are: number one, this improves not only your muscle strength and stamina, it does that, but it improves your quality of life. It makes you feel better. A lot of times the medicines we put you on don't always make you feel better, but this is something that you can have control over, that the data has shown, at least in pretty good size series, makes you feel better, and that's huge. And then the second thing is, don't be afraid of the exercise. Go slow, but build up to your personal best. And we as the medical team ought to be supporting you in that, because that's ultimately going to help you live longer and feel better while you do it.
Yeah, we can actually do questions later, where I tell patients you can't do deadlifts and you can't do sumo.
Yeah.
Everything else works as long as
I recommend sumo to my patients.
Okay, so what kind of, what's the type of exercises that, we can do? So Rebecca is my nurse, my coordinator. We've been together for, I don't know.
7 years?
7 years, yes. It sounds like 7 years in Tibet, I guess. So she's going to talk about the type of exercise that we are counseling the patients, to do. Because that question comes up all the time.
Right.
Should I do it? And what should I do?
Sure. But before that, I want to go back a little bit to cardiopulmonary rehab. In terms of our clinic visits, when a patient's first diagnosed, typically a part of that diagnosis or after that diagnosis, a CPET is involved, a cardiopulmonary exercise test. So that kind of gives us a guideline as to what the patient's abilities are and what the patient's comfort level is. So it gives us a guideline. So after that happens and we refer to cardiopulmonary rehab, as Dr. Fox had mentioned, that it's a 12 to 15 week program with a commitment of 3 times weekly. And what that session builds down to in a given day is that the exercise is working both upper and lower extremities, right? Upper and lower extremities, not at the same time, as we don't want to increase the blood pressure too much. So what that upper exercise would include is, maybe with or without weights, but we're starting off slow. We don't want to go over the limit and overexert ourselves. So we might use some weights, 2 to 5 pounds. But what does that translate to in a given day? When you do these programs, what does that translate to? That translates to strengthening, like has already been mentioned, your diaphragm, helping you to breathe better, right, in your activities of daily living. I'm the nurse, so we're talking about activities of daily living. How does that translate to? That translates to being able to carry groceries or make dinner or, also take a shower more effectively and comfortably. And with those lower extremity exercises, how does that help? That helps with increasing your exercise, your walk distance at home. Maybe, or maybe not. Maybe just making you feel better. You're feeling better with, walking around. I live in New York City. So your apartment or walking to the local bodega. I mean, this is what a session would look like. But also during the session, you have to understand there's also a multidisciplinary team in a cardiopulmonary rehab program, right? It's not just doctors and nurses. It's nutritionists. It's physical therapists. It's also, they're teaching you how to breathe more effectively. They're talking about lifestyle changes to help you with the activities of life. So in terms of exercise, we always recommend and refer our patients to cardiopulmonary rehab. But for whatever reason, we do know this is the age where not only do we have issues with insurance, with medications, but we also might have issues with cardiopulmonary rehab from an insurance standpoint, specific to New York. New York managed Medicaids don't pay for them within our hospital setting, but that does not mean that there aren't opportunities or private places that we refer to that do have that available for you. But first and foremost, if you're going to go outside, if you're going to exercise on your own, there's a couple things that we really need to be clear about. Your pulmonary hypertension physician and staff, they need to know what your thinking, and it needs to be discussed what you have the ability to do. Because whereas patients who at rest do not require oxygen, when you start exertion, I mean, we know this, right? When we start exerting ourselves, you might require oxygen, and that's something that needs to be addressed prior to any kind of exercise routine. Also, I highly encourage, and we often find that our patients who are on oxygen do not have a pulse oximeter. Does everybody know what a pulse oximeter is? Okay, good. It's very important that
She's locked and loaded. She's got hers.
It's very important that you have a pulse oximeter, right? Because you need to know that it's, your oxygenation needs to be between 92 and 100, right? To be able to perfuse your organs. It's very important. So if we're exercising outside of the context of a cardiopulmonary rehab program, if we're riding our bike 20 minutes 3 times a week, or if we're walking and building, of course, we're starting on the low side and building our stamina 20 minutes a week. It's something that we have to know that if we are experiencing chest tightness or pain or palpitation or more increased shortness of breath or lightheadedness, these are things self-limit. We can't push ourselves, right? We have to take it slow. We definitely, for light to moderate activity, swimming, great exercise, but it's not something, obviously, if you use central line, that's really, that's not what we're supposed to do, right? And certainly, well, don't talk about our patients, no. And if we are going to swim, it should be in a more controlled environment, flotation device so that you're not moving your arms and legs at the same time, and you have the ability to rest. These are,
And never swim alone.
And never swim alone. Very important.
Never drink alone, never swim alone.
So, back to the cardiopulmonary rehab programs, know this too, that if you do complete that course, that 12 to, in our case in New York, 12 weeks, but in other places I've heard it's 15 weeks, there are maintenance programs too available at a nominal fee after you finish those programs. I mean, in New York, I think I've heard $50 a month that you can still utilize all the services within the cardiopulmonary, facility. So I'm trying to think, is there anything else that I can think of? I think that's about.
I think we are okay.
Oh, yoga. There's some apps, by the way. There are some great apps. Certainly look at the PHA because they have some great exercises as well as they suggest some apps. I know that Dr. Raina Adish came up with a yoga app on how you can do yoga, chair yoga, and then build up. Obviously not hot yoga, right? We're not exercising in extreme temperatures, no cold, no heat, no humidity. Do it in a controlled environment, do it safely, but get moving and do it 3 times a week. It's important to continue with consistency to see the best benefit.
Okay. I think we are ready for questions. We have exactly half an hour. So, okay, I think that was the first hand that went up. I know you, I know you, I know you. Okay.
Since we are recording this, please try to speak into the microphone.
I can address part of that and I'll leave it for the rest of the panel. But I think, first of all, in exercise programs, they do a little bit of strength training, but it's under supervised conditions. If they're using little dumbbells, it's usually only half a kilo to 1 kilo. And then they sometimes use these TheraBands and things like that. I think in general, trying to do isometric exercise in pH is not a good idea, okay? And then you demonstrated what you do. You lift the weights like this. Well, it turns out that if you, and people have done the studies, if you lift your arm above your head, the amount of oxygen that your body requires increases. It's called the oxygen consumption. And that's why in rehabilitation programs, whether it's for pH, for COPD, for whatever, people will say, in the kitchen, don't have your plates up here, because if you lift your arm up there, you're going to have to work harder. You have it lower down. So the exercise that you're doing, I think, and it makes you short of breath, I don't think that's helpful. And then also, if you're bringing it above like that, that's also not a good technique.
Right, so one of the recommendations in rehab, at least in our rehab as Rebecca was saying, no simultaneous upper lower extremities, and as Dr. Lewis was saying, not lifting them above your shoulder level. Exactly for this reason. So we have a good explanation for you being more short of breath when you do that maneuver than if you do even isometric exercise at a lower level.
So if they have in your closet, so you have like a box in the closet on the top shelf.
You get hubby to pick it up. He's got to do something in the house.
Yeah.
Okay.
Just,
Yes, we actually, we were waiting for a question up there.
I have two questions, kind of piggybacks on what you were just saying. Is it safe for PH patients to, say, lay flat and do like a chest press? Or is there a particular position, should you always be standing? Should you always be sitting if you're doing a light dumbbell? And then the second question is, my mom has PH from scleroderma and has Raynaud's. So when she exercises, for example, she does a spinning class 3 times a week for an hour. Yeah, she's pretty awesome. But she wears a pulse ox, and it's completely inaccurate because it's on her finger. So do you know of any way that we can get a headband, pulse ox that would be more accurate for somebody with connective tissue disease?
The second part of the question is simple. They have headbands also. They have for the earlobe. You can find them on the internet. So that's simple, and that will be more accurate. The other part of the question, I
think in general a bench press is, the way that I think about this is a little bit like Dr. Lewis said. Anything where you're, over the head, that's going to be much more difficult. There's also, I've read some theories that the blood flow during that time when you have arms up over your head just changes. The way, not only the oxygen consumption, but the way that the blood actually flows and returns to the heart can be obstructed or inhibited, which in our patients, is not ideal for obvious reasons. As it pertains to really part of your question, and then for that as well, I think one of the challenges with lifting, going to lifting heavy weights or pressing weights, is that often when we're doing that, I remember in high school when I would bench press, like all of 75 pounds, because that's all I could ever do. But when I would do the bench, you'd take a big breath in, that's that whole decreasing our preload in our heart or increasing the pressure in our chest. Breathing through your exercises is really what I think a big part of this, maintaining a good respiratory pattern, because as we've talked about, oxygen delivery is going to be impaired to those muscles. So for that reason, a lot of the strength training, I think, is, like a cycle, things where you can increase the resistance a little bit, they have the same thing for the legs, so you're not doing them simultaneously. Things like that focus a little more on the endurance with a little bit of resistance are what I tend to recommend. I don't know if these guys would echo that or not, but I think that takes away the suddenness of I'm going to go from lifting 0 to bench pressing whatever it is I can bench press. And I think that as a general rule is going to be much safer. So I like the cycling, and the fact that she can do it for an hour puts me to shame, unfortunately.
Right. Yeah, we echo what you said 100%, Dan. This is what we say as well.
Hi there. I guess this is just kind of confirming what you said. I've always veered away from pulmonary rehab because I do very well breathing. I can take stairs, and I know what it's like to not be able to breathe. And so now that I can, it's good news. But I have extreme muscle atrophy. So would pulmonary rehab help those of us with scleroderma build these kind of muscles? I always looked at it as it's a lung thing, not a overall well-being. I guess my question is, would pulmonary rehab be beneficial for somebody like me who needs to work on overall muscle atrophy?
I think all rehab programs should have the ability to individualize for patients. I think one of the core features for rehabilitation or just exercise in general is, walking or cycling is the best. Aerobic exercise is the best. So if someone had to say to you what one thing would be the most beneficial for me, that would par excellence be it. But programs can work on maintaining strength and ability, but in certain conditions, systems may be upregulated that result in muscle protein breakdown, or you may be on agents that help to promote that. So, for example, patients on steroids that will facilitate breaking down of muscle, or if people get infections, that will help to promote for a period muscle breakdown that may be difficult to maintain. So I think keeping aerobically fit and then keeping your muscles in tune is probably the best goal. Trying to build up the muscles like a weightlifter is probably not the best idea, but there certainly are techniques that can be used to, keep them in tune.
Yeah, I want to talk briefly just about the scleroderma part of that. I think that because scleroderma we know is a systemic disease, even more than, or as much as, if not more than, pulmonary arterial hypertension. There are two other things that go into that. Number one is scleroderma can have a malabsorption part of it. So the nutritional parts, I think one of the benefits that you get at a formalized cardiopulmonary rehab is the nutrition benefits. So, I would make sure that just that is optimized, kind of as a simple thing. Am I getting the protein I need? Am I getting, to build muscle? And then, the secondary part, very much like what Dr. Lewis said, is just the, adding weights to what you're doing can be fine, but again, it's very important that that's done in a very supervised situation, certainly to start, and if not, always. That would be my advice.
Yes, I have MS, and for 16 years, and then 4 years ago they discovered that I have pulmonary arterial hypertension. So my question is, what is the goal? My doctor told me that my pulmonologist told me that I have to walk in the 6-minute walk at least 320 meters, okay? So when I walk 180 meters, I was a little frustrated,
Sure.
And then I tried to walk 280 meters. Well, I say, well, not too much. And then I increase and increase. And now I am in 360 meters. That is, for normal person, it is the media, I have to walk 320 meters. So I say, well, I have MS, so it's good. But if I want to increase, how, not affected my MS with a lot of exercise,
Yeah, I can take
what is the media of?
Yeah, let me just clarify one thing for everybody here. Doctors are, coming up with all sort of magic numbers. These are all magic numbers, okay? So they don't apply for everybody in the room. They don't apply to MS. They don't even apply for, the 320 meters that you mentioned. That comes from a study that was done in patients with idiopathic pulmonary hypertension. No scleroderma, no liver disease, no other things that could affect the exercise capacity. So the 330 meter, it's a magic number, okay? So, we don't even, we don't even go there. And you're absolutely right. You are, 1,000% right with that one. It's not one size fits all. Absolutely not. So it's okay. How can you increase? I think Dan wanted to answer. So, or Dr. Lewis?
Yeah, I don't know if you've been to a pulmonary rehabilitation program, but I think if you haven't, that may be something worth doing, because not only do we aim to improve the underlying pathology or pathophysiology, but what they should also be teaching subjects and participants are more efficient ways of doing the same thing. And so what we find, and this is the case, with the studies, and it's the case with probably every good pulmonary rehabilitation program in the country, the vast majority of patients, by far have significant improvements. I also agree there's no magic number. The numbers that are quoted in the literature that reflect, how a patient does, are just aggregate numbers from the literature, and I think everything should be individualized.
Yeah, I'm just going to be very brief there, but the goal for this, particularly as it relates to cardiopulmonary rehab, it's not to get you to a number. It's to get each of you as individuals to get to the best that you can be, right? I mean, why are we doing this? I mean, as a doctor, when we dumb it down, we're trying to make people live a little bit longer and maybe a little bit better, right? And if you can walk a little bit more and move a little bit more, most people feel a little bit better. So why are we doing cardiopulmonary rehab? Well, maybe you feel a little bit better. So, and we just want to help you do that safely. So if 320 is your goal, doggone it, I hope you get there. But, you know, if you feel better walking 300 than when you used to walk 180, good, kudos to you, brother. You know, great, that's awesome. You know, our goal ought to be to individualize this so that you do the very best that you can. And if you think about it like that, then I think you're thinking about it all right.
If I can just make another point, because I think this is really important. The other thing that in the studies that were done and in practical pulmonary rehab programs are to educate patients on when to stop. When you're at home, it's probably best to go walking with somebody, but you should be aware of the symptoms that say, hang on, this is time to stop. So if you're starting to feel a little dizzy, that's time to stop. If you're starting to get a little bit of chest pressure, that's, you know, time to stop. If you feel that your heart's racing too much, that's time to stop. There's no harm in stopping and resting and getting back to where you think you could possibly go on, or that's it for the day. But you need to know you mustn't exercise to the point where things are going to become dangerous.
I'm a long-term survivor. I was diagnosed in 2005, and I'm hearing about these rehab programs nowadays. But when I was diagnosed, it was the first thing they told me is, hey, go to the couch, connect to the oxygen machine. And I think that's not anymore the case. But just to share my story, I'm right now bike riding. I usually do between 20 to 30 miles a weekend, and the maximum distance I've gone is 30 miles, and I'm trying to prove myself, and probably next year I'm going to try to do the coast-to-coast in Florida. That's 180 miles. So the sky is the limit.
Yeah, right. Things have changed, actually. You know, literature is, you know, becoming, you know, more and more elaborate, and we learn more and more about this one. And as a matter of fact, at least by some guidelines, enrolling the patient in an exercise program, in a cardiopulmonary rehab program, it's 1A recommendations. Very few things have this, you know, degree of recommendation. 1A means I feel that's a strong, so how I feel, and the letter is how much literature backup I have to tell me, yes, I should recommend with that extent. So it's a very clear recommendation. We should exercise the patients nowadays. Again, it's individual patient. If you know, in florid right heart failure, you know, probably we should be more careful. Certainly, we are not doing 3,000 pounds lifts, and you know, we favor gradual aerobic exercise and so forth. So yes, they are, you know, a couple. And again, I always tell the patient, you are the one that is establishing the limit. You know, please try to stop before you pass out. That's, you know, that's the joke. I know you had questions, and I know there were questions in the back. I know that. Yes, I've noticed. Yes.
I'm a 25-year survivor. I've been exercising for 15 years. I do chair yoga, silver sneakers, and I have been on a transplant list. Now I'm off of it, and I feel great. So I definitely advocate exercise.
Thank you.
That's a good testimony. Yeah, good.
Thank you, and congratulations. You're doing more than anybody at this table, I bet you.
Hi, I'm so glad I attended this conference. I'm a yoga teacher, but I was diagnosed in 2004, but my doctor didn't care, didn't even mention it. Up to now, he still not really care. But luckily, I learned yoga in early 90s or later 80s, and I found when I was practicing yoga, that's the best time I can breathe in, I feel good. So from 2003 to I got my yoga teacher's certification. Then I started teaching twice a week. I never stopped. The reason why, because that stimulates myself, keep going on, and in order I can teach. So when I'm so happy when I come here, I see the program, yoga. I was, wow, the professionals realize that's the things can help everybody. That's what I want to really encourage everybody. Doesn't matter how deep you can go, but get a good yoga teacher teach you how to breathe properly. I can see, I'm observate people here, and the people with oxygen, I don't agree with the way they're breathing. Too shallow. They have to practice do proper breathing in order to extending your lung. Your diaphragm is the most important organ in order you can breathe in properly. I hope everybody go home and find a good teacher.
We also have a question in the background, yeah. Because, yeah. All right.
Exactly. I have one comment and one question. The comment basically is, yes, of course, yoga and all those things really help. I went to pulmonary rehab for a month. The question is, I don't know how many of you have been to pulmonary rehab. If not, then there's a little insurance issue also that I faced personally. You may face, so you need to keep in mind that the insurance, most of the insurance they don't cover, if I understand. And what I did was, they charged me $80 or something a month. For first month, I went a month and then learned all the techniques. And then I went to the $10 gym nearby my house, and I did the same thing exactly with the same. I made a copy of the description, all those. And oximeter you'll get in $10, $15, right? And then all those things you'll get easily, And then even biking, you can get $100 or something, in a good deal. So I think that may help you rather than paying $80 every month going to a rehab. And rehab is really great. That helped me a lot. And of course, there are now online resources, a lot of things. What you can do, what you need to do, you get online. You don't even, I'm not trying to run off the business of pulmonary rehab, but anyway, it will really be helpful. That's my just comment. And my question here is, I know exercise, it depends from patient to patient. Some may not be able to do heavy and other may require heavy. In my particular case, even in 6-minute walk, I could easily cross 400 or 500, comfortably. And my nurse get like worried. Oh, your stat is down to 70. Stop it! And I'm like, no, I can go. And is there any? What exactly is the measurement? Is it just oximeter, or is there something else, or you keep on doing until you pass out, or is there any certain limit, whether it's too extreme or whether it's too low? Is there any exact measurement for the people? Thank you.
So great comment, great question. So for the comment first, I agree. There are, the goal is education, I think, by and large. The supervised, initially I think is really valuable, but the goal is to teach you to learn your bodies, basically. And, if you find what's healthy for you, that's great. With respect to the question, I think this is an important question. I want to make sure that everybody understood it. Is, when I walk, I may desaturate to 72%, but I feel okay, and I can keep pushing myself. Is that okay? Did I restate that appropriately? So, when we think about kind of from the physiology, why do we care about that 88, 90% oxygen saturation? Because your doctors probably said 92 to 100%. In Denver, we tolerate a little bit lower because we're up at a mile, but 88 or higher. The reason for that is that when we know this from having done studies on patients and animals and all sorts of things, is when the oxygen concentrations in our bloodstream drop below that creates what we call a vasoconstrictive response. Vaso means vessel, constriction means it gets tight. So you take blood vessels that are already tight, put low oxygen in them, and they get tighter. And when we think about how hard our heart is already having to work, low oxygen levels make it even harder. So the reason that we care so much about that is in patients with abnormal resistance or abnormal work that they have to do, to move blood through their lungs. That low oxygen level makes it even harder and can make it dangerous. So your situation may be a little bit specific if you have a shunt or something like that. That can all come out, and that may be the case for some people here. But in general, when you're exercising, I think this is a key point. If you use 2 liters of oxygen at rest, great. But if you need 8 or 10 or more when you exercise, it's important to keep those oxygen levels up. So working with your practitioner to identify the appropriate amount of oxygen for you is a key thing, okay? And I would not underestimate that. And maybe you are on room air at rest, but you need 3 or 4 liters when you exercise. We have a lot of patients like that, and they say, well, I feel okay. I'm like, I know, but our goal is to keep you safe. So I think as you exercise, my advice to you would be to find the amount of oxygen that you need to keep those oxygen levels up, because it will actually allow you to do more, number one, and number two, it keeps your heart and the blood vessels associated with it safe.
Well, he kind of touched on some of my concerns, and that is my insurance denied pulmonary rehab. Yeah. So what I wanted to know, do you guys have any resources that we can get from you to, go through the nutrition portion, exercise portion? Do you have any information?
Yeah, so Caring Voice Coalition was going to be my thought as well. I have had some success for a couple of my patients actually appealing to the insurance company like you would for a drug denial. Say, I write a letter and say, this is imperative for this patient's health. And I've had success with that a little bit. The other option that you can occasionally, that your practitioner can kind of advocate for you is occasionally cardiopulmonary rehab centers will donate at least a portion of that. And kind of do that pro bono. Again, that's a little more rare and center-to-center dependent, but there are some, at least in Colorado, we have some options for that. So I would, if you've already gone through Caring Bridge, I would go through, I would go to your practitioner and say, is there anything you can do here to try to get me in? Because I do think it can be valuable.
And they can also appeal, actually. They can make a phone call for you. And because it's evidence out there that, rehab is of benefit in pulmonary hypertension. It's no doubts about that. Yeah. Also, just let me know and I'll use my gun. Because I have,
Actually, I think also, doctors in speaking to insurance companies can remind them that pulmonary rehab is a grade 1A recommendation. So, they don't really have much to go on to say why not.
This actually was my question the whole time, was some of us are fighting to get into these programs. And like in my medical facility, they have it for COPD because it's much more recognizable and there's more funding behind it. So they do that. And so they've kind of snuck a couple of us in to the COPD pulmonary function. But we're trying to, the 3 or 4 of us who are in this program are trying to come up with resources, like written material resources to give to the respiratory therapists who are running this program, who look at us and they're petrified when we start out with our resting heart rates are much higher than the standard COPD. And they're looking at us and they're like, are you okay? Are you okay? Are you okay? And we're like, yeah, we're okay. We're happy to be here. But are there standard guidelines that we can give to these respiratory therapists or any program, even these people who are going to regular gyms? We really need to have some type of written material or guidelines to provide to the people that are sort of overseeing these programs, because we really, us as patients, we want to do this, but we want to do it in a safe, educated manner.
Yeah, I think that with regard to the personnel at your pulmonary rehab program that deal mainly with COPD, there are materials out there and there are the studies out there that they can read and see what the protocols were that were used, for example, in the Gruneck study. But I think probably a good idea is to contact a rehab center that is skilled in dealing with patients with pulmonary hypertension, because, not all of this is written down and a lot of it is just experience and so on. So I think it would be worthwhile them contacting a program that deals with pH.
This is going to be our last question.
Hi. I'm a physical therapist and a patient, and I was diagnosed many years ago, and I was a very lone voice in the wilderness regarding exercise. I was the only one advocating it at the time. But I wanted to answer this question about resources. If your insurance won't approve the pulmonary rehab, what you may possibly be able to get them to approve is 4 or 5 visits to a physical therapist, who could then set you up with a home exercise program, maybe see you once a week, once every 2 weeks for 4 or 5 visits, and get you going on a plan and tell you how to progress and tell you what to watch for in terms of symptoms. So very often the insurance will pay for physical therapy on an individual one-on-one basis for 5 or 6 visits instead of a whole 12-week program. So I would suggest that, if at all possible, with your insurance company.
That's actually excellent, and I learned something too. Thank you.
Do you guys have any closing comments?
How hot is the water? Because the problem is if it's very hot, your blood vessels are going to open up and you're going to steal blood going to the heart. So if it's not hot, I guess it should be okay. It should be okay, right? If it's not like 100 degrees.
As long as it's supervised and somebody's there.
Yeah.
Well, thank you for all the great questions. Do you guys have any closing remarks?
I just want to say kudos to all of you. Please stay active, do it in a supervised way, and I look forward to seeing you out walking and doing your bikes. Congratulations to all of you.